We'll get started this morning. Welcome everybody to June Grand Rounds. This is one of several of our annual research grand rounds for the department, where we have our faculty kind of tell us what's going on with research in more detail. So this morning, our speakers are Dr. Meghan Flanagan and Dr. Jonathan Sham. I think both are well known from the department, having done their initial general surgery training and research time here. After that, Dr. Flanagan did receive a master's in public health as part of her research time, and then went on to a breast oncology fellowship at Memorial Sloan Kettering Cancer Center. She returned to the University of Washington in 2019 as a faculty member. She's currently the recipient and/or primary investigator on 5 separate grants, totaling over $400,000 of funding, and the author of 27 journal articles. Dr. Sham, after completing residency here, went on to a surgical oncology fellowship at Johns Hopkins, and currently is completing a master's in biotechnology, enterprise, and entrepreneurship, also from Johns Hopkins University. He returned to us as clinical faculty in 2019, and he is currently the PI or recipient of over $225,000 in grant money and other external funding, and is the author of 29 articles. So clearly, I think we have 2 fantastic speakers this morning, but I think that's no surprise to any of us. And interestingly, they are both current recipients and principal investigators of a Swim Across America Young Investigator Award. So Dr. Sham, Dr. Flanagan, thank you so much for joining us this morning, and tell us what's going on in your research.
So I believe I'm going first. I'm going to try to share my screen. Can I share my screen?
You should be able to without issue.
Okay. Hopefully everyone can see that.
It looks fantastic.
Great. Thanks so much for the introduction. I presented here, I think back in October, looking at the role of this gene HSD3 beta 1 in postmenopausal women with breast cancer. And so I said I would have an update, and here we are. I actually, full disclosure, just got the data for this about 2 weeks ago, and we're working through it. So this is very preliminary, but exciting, I think, nonetheless. Just a quick review of estrogen biosynthetic pathways in postmenopausal women. Most of this is extra adrenal synthesis. So the adrenal gland makes these adrenal androgen precursors, which ultimately are converted to estrogen and estrone, which go to stimulate the estrogen receptor among women who have estrogen-sensitive breast cancers, which is about 70% of women who develop a breast cancer. Estrogens play a significant role in breast cancer progression via stimulation of the estrogen receptor alpha receptor. And there are various different types of treatment for estrogen-sensitive cancers, all of which essentially have to do with the interaction of estrogen with the estrogen receptor or production of estrogen in the tumor cells. The specific one that I'm interested in is the bottom, which is a class of drugs called aromatase inhibitors, which actually just decrease the extragonadal estrogen synthesis. And this is a class of drugs that's given to only women with postmenopausal breast cancer. Unfortunately, about 1/4 to 1/3 of women ultimately end up developing endocrine resistance. This can either be intrinsic, meaning that women have some sort of resistance to these classes of medications before they are treated, or it can be due to therapeutic pressure from the treatment itself, and this is acquired resistance. There are very few biomarkers that can predict the response or resistance to endocrine therapy, and there's definitely a need, given the proportion of women who have these estrogen-sensitive tumors and develop resistance, to study alternate agents or novel targets to help manage these endocrine-resistant tumors. So this is just a quick review of the actual HSD3 beta 1 gene. So a person can be born with 2 wild-type copies of the gene, which is homozygous wild-type, or the AA position. There's a single nucleotide polymorphism that can occur among some patients where the A converts to a C, or in some people, they have a homozygous variant where they have 2 copies of C. Tumors can also acquire these mutations, and that's through a process called loss of heterozygosity. And so we sort of have to think about this as both patients or population of people who have been born with 2 copies of the homozygous variant versus those whose tumors have acquired it. And most of the research I've been able to do so far is looking at the germline, or the people who actually acquire the variant in every cell of their body. The point of this is that the HSD3 beta 1 gene encodes an enzyme called 3 beta HSD1. And in some patients who have this homozygous variant over here, the CC, 2 copies of the CC, this enzyme does not get degraded in the cell. And so it drives the conversion of the adrenal androgen precursors through to their ultimate end product. This is looking at patients, a tumor cell in a prostate cancer patient. And you can see over here in the column with the wild type, DHEA is the adrenal androgen precursor, and it's just sort of slowly metabolized over time. Whereas in the variant, where this enzyme is just constantly working, it's driving this reaction, and you can see DHEA is metabolized very quickly, and the metabolites for androstenedione increase in the cell, and then ultimately DHT increases in the cell. In prostate cancer patients, DHT is a very strong agonist to the androgen receptor, and the androgen receptor functions much like the estrogen receptor does in breast cancer patients. So the men who have this mutation do significantly worse because their androgen receptor is just constantly being stimulated by DHT, and they progress through to castration-resistant prostate cancer, meaning the drugs that we give prostate cancer patients, anti-androgen drugs, are sort of overwhelmed by in patients who have this homozygous variant. This is a Kaplan-Meier curve, and it basically just shows the median survival of the 3 different genotypes. And you can see here that the survival is significantly worse for patients who have the homozygous variant, and that's statistically significant. So what is the data about this gene and the expression of this enzyme in breast cancer patients? There are 2 studies that have looked at this. And I will point out that neither one of these studies look specifically at the SNP or at the variants. And they didn't quantitate protein expression at a cellular level. These are just looking at immunohistochemistry and staining of the enzyme in the cells. So a little bit different than the research that I'm doing. Essentially, they showed completely opposite results. In this particular study on the left column here, on the left graph here, there were 44% of patients that expressed the HSD3 beta 1 gene, and they did worse. On the panel here on the right, about 78% of them expressed the gene, and they did better. So there's really a lot of data that needs to be collected on sort of how this is working in breast cancer patients, and that's the goal of my research. So the 2 sort of main goals that I started out with in doing this research, one was just to establish the allele frequency of this homozygous variant in breast cancer patients. And the second was to try to associate this with any types of outcomes. And given the similarities between prostate cancer and breast cancer, my hypothesis is that the homozygous variant allele will have the worst outcomes in breast cancer patients. And this sort of reviews the way that I think that this is probably working. So aromatase is a very important enzyme in breast cancer patients. It inhibits the conversion of these it allows the conversion of these adrenal androgen precursors to estrogen and estradiol to go stimulate the estrogen receptor. Aromatase inhibitors is a really important mainstay class of drugs for women with breast cancer because it inhibits this conversion. Women have increased DHT, which goes to stimulate the androgen receptor. And in women with breast cancer, this actually causes inhibitory effects, and they have decreased estrogen receptor activation. With the enzyme that is constitutively activated or resistant to degradation in the cell, my hypothesis is that the increased adrenal androgen precursors interfere with the binding sites on aromatase and overwhelm the aromatase inhibitors, leading to essentially intrinsic resistance of the aromatase inhibitors. And this increases estrone and estradiol, which then can go on and stimulate the estrogen receptor. So in order to establish the allele frequency, we recruited 29 patients with metastatic postmenopausal estrogen-sensitive breast cancer. We obtained blood samples from these patients, and found that the germline allele frequency of these patients was 26%. We were hoping that getting metastatic ER-positive breast cancer patients may show enrichment for the homozygous variant. It did not, but a frequency of 26% aligns with population-based cohorts and also those in the prostate cancer groups. And then this is the study where I've just recently gotten some pretty exciting data. This was trying to look at the 3 different genotypes and the association with recurrence. One of my collaborators at the Fred Hutch has done a population-based case study. Case studies, essentially, in this circumstance, they recruited estrogen positive, HER2 negative patients, triple negative breast cancer patients, and estrogen positive or negative and HER2 positive patients. And they wanted to go back and look at environmental factors, hormonal factors, different exposures, and also compare the mutational landscape of these different breast cancer subtypes. Women to be enrolled in this study had to be 20 to 69 years old. They had to have their first invasive breast cancer, and they were diagnosed between 2004 and 2012. They obtained demographic, epidemiologic risk factor, tumor treatment, and follow-up data as a course of the study. And I just put an asterisk by the follow-up study here or follow-up data because the study started in 2015, and we went back in time and ascertained cases starting from 2004. So some patients have 10 years of follow-up data and some patients only have 3. The primary objective of this study was to evaluate the associations between germline HSD3B1 variant, or the CC homozygous variant, and recurrence. There were 644 postmenopausal women who had estrogen-sensitive HER2 negative breast cancer, and significantly that also had germline DNA to contribute. This was either through a blood sample or a buccal swab. And the median follow-up was 4.7 years, and this was either the time to first event or a recurrence or at their end of follow-up. And I'll point this out later, but the significance of why I kind of underlined and italicized germline DNA is that for the whole Bravo cohort, the women could be enrolled if they were deceased because most of it was medical record review. However, my cohort is a special cohort within the case study because my patients had to be alive to give a blood sample or a buccal swab when they enrolled in the study. So we first looked at the germline allele frequency among these 635 patients. There were 9 patients who were unable to be sequenced. And we found that 47% of patients had the wild type, which is 2 copies of AA, 44% were heterozygous, 1 copy of A and 1 copy of C, and 9% were the homozygous variant. This results in a germline allele frequency of about 31%, which is consistent with all the population-based estimates. So here's looking at some of the data. You can see in the 3 columns here, we have the homozygous wild type, the heterozygote, and the homozygous variant. And you can see that there was no difference across all 3 genotypes with median age at diagnosis, year of diagnosis, a family history of a first-degree relative with breast cancer, hormone replacement therapy use, or BMI. There was a significant difference across the 3 groups with respect to race. And specifically, the homozygous variant subtype was much more common among non-Hispanic whites, which is seen in some of the population-based cohorts. I mentioned previously that this variant does vary by ethnicity, and it's most commonly seen among Caucasian people of Western European descent. When we looked at tumor characteristics and treatment characteristics, you can see here there were no statistically significant differences between the groups. But I will point out that there were some frequency differences, and some of this may be secondary to just sort of low numbers. Women who had the AA and AC tended to have lower grade tumors than those who had the homozygous variant. Women with the homozygous variant had a slightly higher frequency of having stage 3 breast cancers compared to the other 2 subtypes. This likely goes along with the fact that more of these women had a mastectomy, or only 52% of them had a lumpectomy, compared to about 2/3 in the other two groups. And then ultimately, more of these women had chemotherapy. Again, none of these are statistically significant, but you can see there is a little bit of a difference in the way that these patients look. I want to point out that a very high proportion of patients did have endocrine therapy. If you look in population-based studies, only about 70% of patients with invasive breast cancer ultimately end up completing their course of endocrine therapy, which is tamoxifen or the aromatase inhibitors. And in this patient population, a very high proportion of them at least initiated endocrine therapy. And then our ongoing analyses will be able to look a little bit more specifically about the actual duration of endocrine therapy use. So what about recurrence and breast cancer events in this patient population? So of all of the 635 women, 5% of women had a second breast cancer event. There were 2 local recurrences, 2 regional recurrences, 1 regional and distant recurrence, 14 distant recurrences, and 12 patients had a second primary, which is in the contralateral breast. This is a fairly low event rate, although in estrogen sensitive breast cancers that are treated with endocrine therapy, we would not expect in sort of a median follow-up of 5 years to have a huge event rate. But I will point out again that this may have to do with ascertainment of cases and the fact that all of my patients had to be alive. So when they gave their women who may not have had the opportunity to give a blood sample, their death may have been secondary to an early recurrence or some sort of bad breast cancer outcome. So my patient population is somewhat enriched to have better outcomes because of that. So this is the meat of the data that we have so far. We looked across the 3 genotypes, and we looked specifically at women who had an ipsilateral or distant metastatic recurrence. So this is a composite endpoint looking at women who had local recurrence, local regional recurrence, or a distant metastatic recurrence. And you can see that the AA group and the AC group had 3 and 5% risk of recurrence, whereas the homozygous variant was quite a bit higher, and this was statistically significant. When we looked specifically just at the distant metastatic recurrence, which really drove the vast majority of recurrences in this CC population, there was also a statistically significant difference. There were no differences in contralateral breast cancer events. And then just to look at this a little bit more graphically, this is a Kaplan-Meier curve. If you look, the x-axis shows years and the y-axis shows the recurrence probability. If you were up at the top corner, this is right after diagnosis, and 100% of women have not experienced a recurrence. And as we go over time, women have recurrences. And you can see there's a significant difference in the patient populations here. The heterozygous and homozygous wild type patients were less likely to have recurrences compared to the homozygous variants, and that's statistically significant. Again, this is very similar when we look at the risk of distant metastatic recurrences, the curves look the same. And I think this is quite significant in that women who have a distant metastatic recurrence in breast cancer, this is really what contributes to their overall mortality. So this is a pretty awesome or awesome finding for me, in the sense that this is exactly what I expected to see, but obviously not great for the patients who have the homozygous variant. When we look at the contralateral primary breast cancer events, there really doesn't appear to be any difference across the 3 genotypes. We have plans for additional analyses. One of the main goals that I have is to assess whether aromatase inhibitors act as effect modifiers across the 3 different genotypes. We do have to truncate the analysis because, as I mentioned, my patients had to actually be alive to be enrolled in the study because they had to give blood. And so it affects how you analyze follow-up and recurrence data. And then we'll need to do a multivariable analysis, including some age, treatment characteristics of the patients. So the results that I have so far is that we've established a germline allele frequency in breast cancer, which is similar to the overall population and the prostate cancer cohorts. This is anywhere from 26 to 30% in the patients that I've looked at. And that the homozygous variant, or the CC genotype, really does seem to be associated with significantly higher frequency of distant metastatic recurrence. The next steps for my research are to look prospectively, just hoping to start up a preoperative endocrine therapy window of opportunity trial in patients who have estrogen-sensitive postmenopausal breast cancers. The primary objective of this study is going to be to look at the effect of a short course of preoperative aromatase inhibitors on the Ki-67 score. And in prior studies, it has been shown that if women who have a consistently high Ki-67 score, despite aromatase inhibitor treatment in this preoperative window, will have worse worse ultimate progression and worse outcomes. And so I'm looking at Ki-67 scores before and after giving this preoperative aromatase inhibitor and looking at these variable by genotype. Secondary objectives is to better understand how the androgen receptor works and whether this works as an effect modifier in these patients, looking at expression of the enzyme specifically to quantitate this, and then looking at intracellular estrogen and androgen levels to better understand how the enzyme is actually working at a cellular level. This is just a mock-up of what the endocrine therapy study will look like. We take a clinical diagnostic biopsy, a corneal biopsy among estrogen-sensitive, HER2-negative patients. The tumor has to be over 1 centimeter and they need to be postmenopausal. We'll look at Ki-67, ER, PR, AR, and actually we'll look at HSD3B1 expression as well. Enroll the patients, they'll get about a month, 3 weeks of neoadjuvant anastrozole, which is one of the aromatase inhibitors. We'll germline sequence them. And then from their surgical specimen, we will look again at the Ki-67 expression of all of these hormone receptors. And then we'll also sequence the HSD3 in the tumor itself to understand whether people are acquiring mutations in these tumors. So that's all I have so far. Lots of work to be done. I'd like to acknowledge Chris Lee, who kindly provided me with all of the DNA samples from the Bravo study and all of the data, and then VK Gowdy, who is my primary mentor on this project. And then also to thank Swim Across America for their funding of this research and the Fred Hutch Cancer Center support grant for a new investigator award to pursue the neoadjuvant window of opportunity trial.
Dr. Sham, I think we're going to continue forward with your presentation, and then we'll do questions at the end.
Sounds great. Share my screen here. Dr. Flanagan is a hard act to follow, but I'll do my best here. Are you able to see my screen okay?
Yep, that looks great.
So thanks again, Dr. Wood and Marquardt, for inviting me to speak today about some of our work in addressing postoperative pancreatic fistula. I have just one disclosure. I do some speaking for Boston Scientific, but it's unrelated to this work. I start with this slide just to kind of remind everyone that pancreas cancer is a bad one. We all kind of know that, but any disease where we're celebrating a 10% 5-year survival means there's a lot of work to do. And headway has been made over the past 10 to 15 years and even longer in the surgical world. If you look back in the data, you'll see that mortality back in the 1970s after pancreatectomy was somewhere around 25%, and now that's down to a kind of respectable less than 4%. However, major morbidity remains recalcitrantly high, and even in 2021, the likelihood of some type of major complication after pancreatic surgery is somewhere around 33%. And chief among these is postoperative pancreatic fistula, or leakage from the cut end of the gland, either a Whipple or distal pancreatectomy of enzymes, which can cause a host of negative downstream effects. And surgeons over the years have tried a lot of things to reduce fistula, different pancreatico-enteric anastomoses, invagination, stenting, drainage, and quite frankly, none of them have worked. And still, again, to this day, we're left with a 20 to 25% leak rate after a Whipple procedure. Distal pancreatectomy is even worse. We tried stapled, hand sewn. People have actually done anastomoses to the jejunum to try and allow the pancreas to drain that way. some institutions actually practice opioid abstinence after pancreatic surgeries to reduce contraction of the sphincter of Oddi to allow drainage into duodenum. It sounds kind of mean, but even despite all of this, we're still left with up to a 50% leak rate in some series after distal pancreatectomy. And so why do we care? Well, it's an important clinical sequelae. You know, you look at the other major complications after pancreatectomy, delayed gastric emptying, post-pancreatectomy hemorrhage, and all of these are more than doubled if a pancreatic fistula is present. And then, of course, there's sequelae of the fistula itself, infection, sepsis, death, which can be important in their own right. The group out of Memorial Sloan Kettering took a look at the actual cost of patients who did and did not develop a fistula, and found that those who did, direct hospital costs were almost double to that than those who did not. And if you kind of extrapolate this over the nearly 10,000 pancreatectomies that are done each year in the United States, this comes out to about $38 million annually in the US each year of increased direct costs. And of course, the kind of outcome we all care about, which is overall survival. Carlos Fernandez del Castillo and the group at MGH looked at survival and the association between pancreatic fistula and survival in the neoadjuvant chemotherapy era with really remarkable results. They demonstrated that postoperative pancreatic fistula was the single biggest predictor of decreased overall survival after pancreatic surgery. For pancreas cancer, of course, this was more than an R2 nodal status. This was more than a positive margin, more than a high CA19, really remarkable result when you look at it. And you look at the Kaplan-Meier curves and you see that those who did not develop a fistula, somewhere around 34-month median overall survival. Those who did develop a fistula, somewhere around 17 months. And so why is this such a problem? Why is this such a recalcitrant problem? And so many authors have likened sewing on the pancreas to sewing on soft tofu. And so there's clearly a leakage, physical leakage issue, but also it's a gland, right? And so even if there's a small leak present, there's just this constant secretion. And we know, we have patients with drains in for weeks or months that just kind of keep going and we can't get them to stop. And so our work is aimed at kind of both of these issues. And so we think that in order to stop a leak, the two kind of main approaches are, number one, stop the physical leakage, and number two, decrease secretion from the gland. And so when we envisioned a polymer to try and do this, we thought, okay, what are the ideal properties? So we want something that's easy to apply. We want something that a surgeon could just kind of spray on at the end of the case. Obviously we want it to be compatible, non-toxic, something that kind of could form to an irregular resection bed. I think this has been kind of the downfall of some of the other approaches where you have like a patch or something that you're sewing onto the pancreas. Number one, you're making a new hole with each needle prick, but also it's not kind of getting into the nooks and crannies, particularly at a microscopic level of the gland. And of course, we want this to be biodegradable so you don't have long-term foreign body reaction over time. And so our approach with my collaborator, Buddy Ratner, in the Department of Bioengineering is to use a polymer called polynipam, which is biodegradable, biocompatible, and thermoresponsive. What that means is at room temperature, so less than 31 degrees, it's a liquid. You can see it falling to the bottom of the flask here. And this allows it, when you kind of freshly apply it to tissue, to kind of completely coat it, get into the nooks and crannies. However, above 31 degrees, so body temperature, it turns into a solid. And so the idea is that once it kind of takes the form of whatever it's over, it locks into place, extrudes the water. You can see little white water or blue water molecules around here, and then provides a seal. You can see here that as you increase the temperature from room temperature to body temperature, the adhesive strength goes up dramatically. The same is true for tensile strength between 25 and 37 degrees. And so this would be great if this just worked, but obviously we're not so foolish to think that just a physical seal is going to be able to do the trick. And so we also want to focus on decreasing pancreatic secretions as well. As many of you know, somatostatin analogs have been used in the past to decrease pancreatic secretions after pancreatic surgery, and these have had uneven results, quite frankly. And many of the issues have been with off-target effects of the somatostatin analogs, abdominal pain, cramping, nausea, constipation. And so we hope to kind of combat some of these off-target effects by using drug-eluting microspheres within the polymer. And so you can actually put octreotide within these microspheres, mixed up with the polymer, and then as the polymer degrades, allows for gradual release over time. And this, we hope, allows for a more local action of the drug without the off-target effects when it's administered systemically. And so this is some drug release data, and this actually is flexible. And so here, the peak is around 20 days, but you can actually, based on some parameters of the microspheres, push this to the left or to the right to make it dissolve more quickly, more slowly, based on your needs. And so this is kind of aim 2 of the project if our physical sealing doesn't work on its own. And so, well, how are we going to test this? And so the last, nearly a year, quite frankly, has been used to develop models of pancreatic surgery, which have really been lacking in the literature. This is the rat pancreas. You can see kind of 4 main lobes that all kind of drain into a pancreatobiliary duct, which is one and the same as the bile duct. And this is important. This is a little different than humans, but this is important in the model I'll explain later. And so when we first started out, we thought, oh, well, in humans, distal pancreatectomies seem to leak more than Whipple's. So why don't we just do a distal pancreatectomy? And so that's what we did. It was really kind of disappointing results. We had really kind of a mild increase for a couple of days, and then it automatically just went down back to baseline. And so we're like, geez, these rats are really good at healing their own fistulas. And we think that it's in part because of this common channel here and some of the fluid dynamics because there's so much bile going past here that it's kind of pulling the fluid away from the cut edge of the gland. And also rats are just they're superior to us in many ways, but are also a little bit better at healing. And so this clearly wasn't going to work just because it wasn't robust enough of a model. And so the pendulum swung the other way and said, oh, well, let's just cut the main pancreatobiliary duct here and get the biggest leak we can. I'll just say that doing this was not compatible with life after 24 hours, and we had a whole host of dead rats. And so that, again, is a little too strong of a model because of biliary peritonitis. And so we kind of took this Goldilocks approach, and we identified the common bile duct as it exited the liver and entered the pancreas here, and we ligated it, which is with a suture to prevent that bile leakage into the abdomen post-op. In a similar fashion, we cut the main pancreatobiliary duct and had this nice kind of pancreatotomy here, where we only had pancreatic juice going into the abdomen, with some really excellent results. And so we had here the pre and post peritoneal amylases, and you can see really remarkably high peritoneal amylases in kind of the $100,000 range, which is robust and continuous. And we actually don't like to keep the studies going for much longer than this because we worry about the animals kind of getting sick, and we want to be humane. And I'll just note that compare this to the 300, 400 peritoneal amylases and lipases that we saw in the distal model. And so we're really excited about this. And so, as many of you who do pancreatic surgery know, the level of peritoneal amylase is not really doesn't really matter in and of itself. You'll have patients who are clinically doing great with really high amylases and vice versa. So really care about the physiologic effect of the leak on the animal. And so we developed what I think is a pretty cool index called the Peritoneal Saponification Index. And this is kind of a nod to the Peritoneal Carcinomatosis Index that many of you may be familiar with, that's used in cytoreduction surgery and HIPEC. But essentially, we measure quantitatively the amount of saponification in each quadrant of the animal's belly, add it up and give them a score. And this allows us to kind of compare apples to apples across, how much is this leak affecting the animal. And so just for some examples here, you can see kind of minor saponification in each quadrant here for a PSI of 3. And some more significant effect here in this animal for a little bit higher PSI score. And that kind of allows us to compare animals post model. And you can see here pretty reasonable correlation between PSI and amylases and lipase as well. And so like Meghan was saying before, we've had a lot of delays because of COVID, quite frankly, lab shut down, animal facility shutting down for a while. And so we actually just, after a year of work, did our first polymer application last week. And so I don't actually have all the data. We're still analyzing it, but we're really excited about it. But I wanted to show you a couple of videos just of what we're doing and kind of how this polymer works. And it kind of allows you to envision what this might look like in the operating room, at the hands of a patient in the future. And so this is just a demonstration of the polymer on a normal rat liver. And you can see we apply the polymer as it kind of hits the rat liver, it spreads out, kind of taking its form. But then as it heats up, so the heat from the liver is being transferred into the polymer. You can see from the edges where the polymer is thinner, it turns white. That's the phase change from liquid to solid. And then that kind of moves more towards the center as the polymer heats up gradually. Sorry about the bubble there. But you can see it within about 10 seconds or so, it turns into a complete solid, extruding the water out. And again, taking the shape of whatever it's on. And this is a video of application to our model. So you can see the liver here, the duodenum, the pancreas, and then again, this is the pancreatotomy, this little hole here. And so you can see the polymer application. You can imagine this is around an anastomosis of a Whipple or to the cut end of the gland of a distal. Again, in a similar fashion, you have the kind of thinner areas at the edge turning white first, that are turning solid more quickly, and then it kind of gradually proceeds to the middle, really nicely sealing that hole up. So a lot of fun to do this. Again, it was a lot of work to get to the point a week ago. Again, excited to see these results. And so just as a brief summary, again, pancreatic fistula is a major cause of morbidity and mortality after pancreatectomy, even in 2021, and is associated with a reduction in overall survival in patients with pancreas cancer. Rats are imperfect, but I think are a good first step. Clearly, if there is a signal here, we will need to move on to a larger animal model prior to commercialization, clinical trials. And again, this polynipam is, I think, a good approach. It is an FDA cleared substance, which really decreases the regulatory burden, which I think is an important factor to consider when you're dealing with commercializing a product, particularly for human use. And then again, we have this backup drug delivery option if the physical sealing properties kind of aren't sufficient on their own. And so I just want to, again, thank all those who supported this work, some across America, the HPVA, the Department of Surgery, and several grateful patients. And then, of course, my collaborators. Buddy Radner, who is the endowed chair for commercialization, the Department of Bioengineering, has really been a huge asset in kind of guiding me through this process. He's been around the block a few times and knows good and bad ideas when he sees them, and he's quick to point out when something is a bad idea, which I really appreciate. And of course, Alan, Kevin, and Arzu for their instrumental work in getting this model off the ground. So thanks so much, and I'll turn things back over.
Thank you both so much for presenting this morning. As usual, I'll start. Actually, I'm going to start with a question, but then we'll have it open for anybody who would like to ask a question in person, and then I'll moderate chat as well for any questions for Dr. Flanagan and Dr. Sham. I think for both of you, not so much to your specific research, but I think for the department, for junior faculty, but also maybe for residents who are thinking of pursuing a very research-oriented track for their career, their academic careers. What has been maybe the most useful tip you could add, right? You both have this fantastic grant that's supporting the research that you presented today. So what might be the one thing that you think has been most helpful to, help you early in your academic careers as faculty to get these grants or approach projects, for example?
You want me to go?
Sure.
I think in obviously having departmental support in terms of time is super important for junior investigators. the clinical work is never ending, as everyone knows, and to have dedicated research time is so important. So number one, I think really it truly is to have departmental support, but I also think having a sponsor or a mentor or someone who can help away is really important. I was struggling to enroll patients and metastatic patients to just try to figure out an allele frequency. And my mentor, Chris Lee, happened to be listening to my talk at a lunchtime grand rounds and was like, hey, I have like thousands of patients that we've already collected data on. You can have them. And so that totally changed the picture for me completely. So I think having someone who can help, even if you have your own idea, having someone who can help you put that into action is so important when you're a junior investigator.
Yeah, I agree completely. Certainly both Megan and I are still in that kind of ramp up period in our careers where, we don't have the immediate kind of clinical pressures bearing, breathing down our necks. And that's super helpful, as you start a career and these research projects. Similarly, mentorship, both kind of clinical and research mentorship. I mentioned Buddy Radner has great perspectives on polymers and commercialization, but doesn't know a thing about pancreatic fistula. And so me being able to bounce ideas off Dr. Park, Dr. Pilar-Setti has been really great. And kind of, I actually have missed kind of dropping by, offices and just kind of shooting ideas around. I would say, more broadly speaking, though, to juniors looking for a career in research is just finding something you're passionate about and not something that you think is kind of high yield, if that makes sense. And what I mean is it needs to be high yield, but don't just go to kind of somewhere that is sexy or popular, because there's most likely going to be a lot of people in that space. And so, I think pancreatic fistula is really interesting, but not a ton of people are doing like a lot of translation or basic science work in that area. And so kind of finding your niche and being able to make space for yourself. Because, at the end of the day, if you're competing with a lot of other people in the same space, it's just harder to be successful, particularly when you're a junior investigator.
All right, I'll open it up for anyone who wants to ask a question in person, and then I'll begin chat. All right, so from chat, Dr. Olschlager says, I notice that you both are benefiting from various forms of philanthropy in progressing your work. What can you tell others about what you have learned about approaches patients or organizations, or about approaching patients or organizations for securing this funding? I'm sure other junior faculty would be interested.
Yeah, I can start with that. I'm smiling because my partners have made fun of me over this a little bit, but my first major grant for a philanthropic gift from a patient was one who just happened to develop a really bad pancreatic fistula. And so because of the complication that led to, kind of more intensive interactions between us postoperatively and kind of a longer term relationship. But I would say, if anything, it kind of was making lemon out of lemonade, and that experience kind of bonded us together and got them invested in my work and in me. And so I think that, again, finding something that directly affects patients in a real way that they can kind of see and visualize, they understand, hey, like I got a fistula, I needed a drain for extra amount of time, versus some sort of conceptual thing that doesn't really affect them, is really helpful. Again, I would hope that I don't have a lot of patients with fistulas that I need to, to go for money. But the point is, with anything, whether it be any kind of clinical diagnosis, a complication, what have you, finding something that affects them directly, I think is important in getting them engaged in the giving process.
I think from my standpoint, having a relationship with philanthropy has been helpful. Mine are all grant related, like I applied for them, and I have several different projects, and the philanthropy group kind of helped me tailor some of the proposals more less science, more sort of story for one of them. And so I think working with the philanthropy group has been helpful for some of these like family foundation awards, and also just having them send me requests to apply. And then when I declined, they sent another one. So, and then I got the grants. So I think that's helpful to have a relationship with the philanthropy group, because they sort of do have a finger on the pulse, I guess, of what is out there that may not be so obvious because it's not like a ASCO or Society for Surgical Oncology award or a career development award or a K award or an RO1 or something like that, but these sort of alternative grants that are smaller but might give you the funding you need to have a pilot that then can propel you, ideally, hopefully, to a larger NIH grant.
Dr. Flanagan, how did you sort of get involved with the philanthropy group? And then Dr. Javid, I think, has an in-person question perhaps to ask. Okay.
Sure. I believe that Martha Lundbeck who's in philanthropy, was sort of making rounds and trying to meet junior research faculty, or maybe all research faculty, specifically in different groups. And so I had a meeting with her, about an hour meeting, kind of shared with her some of the projects I was interested in or thinking about. And then she kind of took it from there and said, well, I'll see what opportunities there are, and has kept kind of up to date and let me know when there's various opportunities coming through. And then I've worked with the larger philanthropy group on some of the applications. Some of the foundation applications are a little less sciencey, because the boards are not necessarily medical. And so that's been really helpful, because they've been helping me tailor the applications to the appropriate audience.
Yeah, I will just add that, yeah, I meet monthly with Martha. She's outstanding. I've gone from like being totally nervous about talking about money with, patients, to really kind of, you're able to kind of put all of the onus on her, right, as the advancement person, and you're just kind of the friendly clinician, and that really it makes it more comfortable to kind of talk about these things, and you can focus on your passions, you can talk about your project, the science, etc. And Martha can kind of deal, with everything else, the nuts and bolts of the advancement work. And so I think that for any faculty here, meeting with her. And she's can help identify patients. They have a whole database that they use, but really, again, I think it's about the relationships. And to Megan's point, she's made me aware of certain grants I didn't even know existed. I like never even heard of them before, and to kind of bring them to your attention, I think, is critical at this stage in our career.
So I had more of a comment on Megan and Jonathan. I'm just blown away by the work you've been able to accomplish, being also busy clinicians side. And I'm so glad, Megan, that the Bravo data actually brings forward your hypothesis and I think marches your own project forward. One concern I would have, and I want to kind of raise the specter of the importance of this, is at Northwest, where most of our breast surgery is currently done, there still isn't an ability to acquire specimens freshly with Northwest BioTrust. And so that's been a big hurdle to initiating, I think, Megan's project, is having the ability to acquire those fresh specimens. And I just want to put a bug in everyone's ear, to make this happen and move forward. I think it has to do with resources, but in order to really foster the success of our investigators, particularly with this translational research, we really do need to make that happen quickly. And so that's all.
Yeah, thanks, Sarah. I think it is, there's so many parts to doing research. I actually, at the current moment, cannot enroll patients onto my own study because I can't get fresh tissue at Northwest. So I'm hopeful that will change soon. But it's, there are a lot of little pieces that need to be in place in order for a successful research project to actually take off. And that's one that you don't necessarily think about until you get there and you're like, wait, how am I gonna actually do this? So yeah, I'm hoping that will change soon so I can start enrolling patients.
We have a question from Dr. Irene Zhang for Dr. Sham. It says, Do you think the association between pancreatic fistula and overall survival is causal, or do you think the fistula is a marker of poor health status or other factors?
It's a great question. The authors of the study obviously point out that this is an association being and not causation, as is a retrospective study, but it's a pretty darn strong association, with a hazard ratio of 2.8. If you notice, the survival curves don't drop off and then kind of flatten out. It's not like people are dying of the fistula in the hospital, right? And then that's accounting for the survival difference. That's something, and they posit likely with the inflammatory process, kind of like you see blood transfusions with lower survival in cancer patients who get blood transfusions, something with immune modulation with that pro-inflammatory process that happens at the time of after surgery with the fistula, but it's unclear kind of the exact cause. Deb, I think you're muted.
Thank you. Sorry. There's two more questions that kind of flow together. One is from Dr. Perrin and then from Dr. Flum. As far as EC fistulas, from Dr. Perrin, do you think that this product, if it pans out in the future, will have other applications, say as post-mastectomy seromas or other things? And then Dr. Flum kind of followed on to say, maybe can you tell us a little bit about the path to commercialization and what unique types of research methods and steps are needed for this?
Great questions. So regarding kind of other applications of the polymer, yes, and that's something that my collaborator is quick to jump on. And so obviously, I'm interested in pancreatic fistulas because I'm a pancreatic surgeon, and because it has immense clinical significance to my patients and their outcomes. But at the end of the day, there are only 10,000 pancreatectomies done in the United States each year. And so, for any product that needs to be commercialized, there needs to be a market. And so others are really focused on looking at other applications. So on the surface of the liver for a bile leak, on the lung staple line after a lung resection, for air leak, things, EC fistula, to your point. So other applications that essentially have a larger population that this could be used for. And the short answer is yes. There's no reason this couldn't be used for any of those. As I mentioned, this product is currently FDA cleared for use in drug delivery in glioblastoma patients. And I pointed that out earlier, again, more to Dr. Flum's question, because the regulatory hurdles into getting something FDA cleared are long and difficult. And so if you can kind of augment something that's already cleared, it actually decreases the scrutiny quite a bit. And so there are different application pathways, essentially for like a new product or modification of an old product. And they have these numbers to the FDA. But essentially, if you can do modification of an old product, it cuts down the timeline by probably 75%, if that makes sense. So that's why, at least to start out, I was kind of focused on this polymer, just because if it does pan out in the preclinical work, the road to commercialization is much shorter, and you don't get caught in what's called the valley of death of commercialization. And that's kind of, you have great preclinical work, but you can't get it to the commercialization because of that funding that's necessary and the timeline that's necessary to get it approved. And so what I envision here is, if there's success with the rat model, most likely, in order to get a company engaged in either a licensing deal or otherwise, we would likely need a larger animal model. And so I'm actually already working with the vets in a pig model, which actually is much easier to do, and we actually have some experience with over rats. And so again, we'll have to see if there's a signal with these first couple rounds.
I think that kind of gives us, Dr. Wood?
Yeah, I have a question for both. First, I just want to acknowledge how inspirational it is to see Dr. Flanagan and Dr. Sham and early success as surgeon investigators, because we all know this is a really tough time to be an investigator, much less a surgeon investigator. And so it's inspiring to me, but hopefully inspiring to other junior faculty and to the residents who aspire to a career in academic surgery. Dr. Flanagan, my question to you is, you have been particularly successful in getting funding at a very early stage of your career. Do you have any tips on just how you've been successful that way for other of your peers and for the residents that are coming along, and see you as a role model? And Dr. Sham, my question to you is, being a busy clinician, like both of you are, and balancing your research work, your scholarship, is more than just protected time. It's also how you organize yourself and how you use that protected time, or how you protect it. Can you give us some tips on how you've been navigating that early in your career? So Dr. Flanagan first.
Yeah, I'm not really sure how I've been able to obtain so much funding. I think that you have to apply. I haven't gotten every grant that I applied for. So you just have to kind of keep applying and reapplying. I think that I have been fortunate enough to have several different projects. One looking at lymphedema work with Chris Calhoun and the plastic surgeons, for which I got a foundation award. I'm working with some collaborators at a different institution in North Carolina, looking at lobular neoplasia and some translational work with respect to that. And then the gene mutation work, both Jonathan and I were fortunate enough to get a Swim Across America grant, and then somehow, because of COVID, I guess maybe they didn't want to do another grant cycle, and so they just gave us more money. Yeah. So that was really nice and helpful. So, I have sort of a couple of pots going, I guess, and I have my mentorship team told me, don't be a squirrel, like going after everything, and so I've been trying to sort of rein myself in and focus on just a couple of projects instead of many, to really be able to focus my efforts. And I think a lot of, much like Dr. Sham mentions, these are really bad clinical outcomes for his patients who have leaks, and some of the lymphedema outcomes and other, doing too much surgery in breast cancer patients are compelling stories. And then if you can sort of figure out how to match science to that, you have interesting and novel grant applications, and I guess they get funded. Sometimes you're lucky.
I'll just add that Dr. Flanagan has outstanding ideas, and those tend to get funded. And so that's part of her success. For your question for me, Dr. Wood, I think that being able to balance is hard, right? I think all of us, particularly, I talk to Meghan often about, how late we're working in the day and trying to balance, a busy OR. But I think that while clinical work is important, I think making this a priority and understanding that, as I mentioned, if I don't book that one more case, it's not going to be the end of the world, right? It's not going to be a big deal, but not doing a couple of experiments over time is going to add up to kind of lack of progression. So I think just being really forceful with yourself, just like anything else in life, exercise, right? Eating right, whatever, and saying, what, during this time, I'm not going to do anything else. I schedule it in my calendar. Right? I schedule thinking about, time to think about grant applications, time to read papers. Like I put it in my calendar, because if I don't do it. And so that's kind of a nuts and bolts recommendation. And then again, like Meghan, have just had some luck with a couple grants, which has then kind of funded the work. But I will point out, we've had support from the department. So to be clear, we've been lucky with grants, but it wasn't totally necessary because of the investment the department made in us when we got hired. And so I think both of us have not tapped into our department support as much as we've needed to because of the grants, but it was always there, and it's that nice safety net that both of us feel and kind of enable us to spread our wings a little bit.
I have one brief announcement, and I know Dr. Wood is going to close out. Thank you both again for fantastic and very inspirational, talks this morning. There are a couple of fantastic grand rounds sessions happening through the Department of Anesthesia this month, and they are doing it still all online. And I will look for an email regarding those. One is next week and one is at the end of the month. So just look for those. It's an additional offering that you can join through the Department of Anesthesia, and they're pretty fantastic.
Well, and Dr. Marquardt, thank you for organizing another great grand rounds. Dr. Flanagan, Dr. Sham, thank you. I just want to remind everyone of the Department of Surgery Education Seminar, always the first Wednesday in June. Required attendance by residents and faculty. Starts at 1 o'clock. I know you all had it on your calendar and are planning to attend, but just wanted a reminder in case it slipped by any of you. See you all at 1.
Have a great rest of your day.